here we go. The election's around the corner. I think we got 1 week away. We are 1 week away from the election. Big talks, a lot of going on. We got to talk about healthcare. We got to talk about the effect of what's going to happen for those. If those of you remember back Affordable Care Act, ACA, when that election was won, you know, it was a State of the Union in my office the next day, and we were a little worried. We thought we might be out of business. Turned out it was the greatest time since sliced bread in our business because people made a lot of damn money. That being said, we got a good show for you today. Craig will be joining us, and the one, the only Hobson Carroll, who loves to talk about healthcare, knows a little bit more than some of us out there, been around a long time, knows politics. I think he likes politics. I heard he's a big fan of Trump. Don't take my word for it. Let's welcome to the show, Hobson Carroll, my friend, and yours. How are you?
Are you on? Did you unmute me? Okay, so I can respond to that. No, I'm gonna play the Tony Fauci line. I'm neutral. You know, I got to be neutral.
You're neutral here.
Yeah, I'm not sure about the politics, but there's a little actuarialness to it, but it's mostly common sense. The stuff we can talk about tonight.
So let's get right into it. Well, with that being said, let me show some of these people here in the crowd, wishing you all a happy Halloween. But let's see here what we got. Let's see who we got. John Clay. Shout out to John Clay taking down a nice broker of record today using the Trojan horse last year, putting his foot down and closing it. Rick, Craig.
Nice.
Mark Fox, what's up? If you are Farmer Fran, you're going to have to access give Grant access to StreamYard to show your name here on the comp. Let's see here. Spencer Gold joined us. Show sponsor, none other than Virtue Health. Check us out, virtuealliance.com. Give us a buzz. But let's get right into it, Hobson. Who are the real players? We all know, they want to take the talking heads of Joe Biden and Trump and say, what's your health plan? We all thought that was Obama with Obamacare, but we all really know now on the healthcare side that the insurance companies wrote the Affordable Care Act. So who do we really have to think about? Who do we have to worry about coming into this election?
Well, I'm not sure the insurance companies wrote it. I think the providers and Big Pharma wrote it as much as anything. Yeah, I mean, the thing was, it's called Obamacare, but Obama...
Hey, close enough.
The administration didn't actually do much recommending or pushing of anything. They sort of sat back and let the other players, a lot of the committees in Congress, write that. And so it had about 150 authors, and none of them knew what the other ones were writing. But anyway, so right. I mean, if you say the players are a lot more than, the main cast, okay, Joe Biden or Donald Trump. Because they can say what they want. Oh, I'm going to do this, I'm going to do that. But that doesn't necessarily happen. Now, the president tries to do a lot of stuff with executive orders that end up not going a lot of places. But in this case, I just want to rattle off some of the cast of characters that are going to have a bearing on healthcare and healthcare insurance and benefits and that sort of thing going forward from, next Tuesday, which I think is only 5 days off, not a whole week. But then there you go. So you've got the president, you've got Biden, but you've got the U.S. Senate is going to have a lot to say about it, and who controls the Senate. The House of Representatives could have a say in it. Obviously, SCOTUS has a say in the path that we're going to take. And what we're talking about is, what does the future 4 or 5 years look like, and what is the pathway we're going to take to get there? And a lot of the pathways end up more or less the same place. It's just they get there over different mountains and different rivers and stuff. So SCOTUS has a lot to say about that almost right away. COVID-19 has something to say about it. The president's executive order on transparency, which, if some of you are up to date on the news today, CMS finalized the transparency rule over the yelling and screaming of the hospitals and the care.
Let's sidestep for a second. I don't want to cut you off, but let's cover that for a minute. What does that actually look like?
Well, it was it's not what they should have done, in my opinion, but it's I guess it's better than nothing. And it's mostly they came out. Trump issued an executive order back months ago now, that basically decided to finally enforce the tiny little section of the ACA that said hospitals shall post their prices. And the problem was that was never done during the Obama administration. Nobody really understood. They didn't want to delve into what does that mean? Okay, which price? Whose price? Etc. Well, the Trump administration came in and said, HHS came in and said, we're gonna just say you have to post your prices, and carriers have to post they have to show the whole price and the cost sharing piece. I mean, supposedly you can go to an announcement from CMS, HHS today, and read about what they finalized on. I'm not sure they really changed much. They had the open discussion period, which is what has just ended, and they've decided to say it. It's going to require a lot of administrative costs to providers, carriers, and third-party administrators, because this impacts the self-insured world.
So the transparency, is it not, what I'm thinking, I haven't read into it. I should have asked Seth to come on, because he's Mr. Politics on this sector. I'm sure he's reading about it. But that transparency bill, who are they requiring to be transparent? Who had to provide it? Was it more? So you're saying it's more than the hospital systems?
Oh, well, definitely. I mean, I've got it right here. Let me just. The departments are also requiring plans and issuers to make publicly available a standardized, regularly updated data file, which would offer for the first time an open opportunity for research, innovation, etc. They have to. It's just a whole bunch of stuff, and it applies to all payers. So that's more than just the insurers. It definitely includes the third-party administrators. So the SPBA was trying to lobby and point out, wait a minute, you don't really mean what you're saying, and a lot of it has to do with the fact that it's more complicated than a couple of words thrown together can explain. Because again, which price? Of course, the big hoo-ha was about the insurers and the hospitals via their networks are going to be required to disclose contractual relationship, the contractual numbers. Okay, how do you calculate your network allowed amount? Okay, is it a fee for service discount? Is it a DRG schedule? And of course, they were all. And it's going to be challenged in court. It's already been gone up one notch. I'm sure it's going to go.
You said CMS approved it today, but that doesn't mean anybody has to abide by the rule yet.
Well, I don't think it goes into effect. I didn't get to read the whole thing, so I'm not sure when they're saying it's going to go into effect. But even if it does, I mean, the AHA is going to be all over this, and they probably already pushed it up to the next notch after the first court that basically, I believe the first court case was settled in favor of the administration. So we'll see where that goes. But it's gonna take time. It's gonna take time for them to even figure out what it all means.
It sounds like a bunch of political bullshit for the time being. Craig,
yeah,
what do you say?
Yeah. Well, it's the same. It's the same with the executive order. For another one of my players is, what's going to be the impact of the executive order that told the pharmaceutical companies what they're going to have to do for drug prices? Now, when they say drug prices, they don't mean drug prices to you and me. They mean drug prices to old people.
Hold on. Let's not skip ahead here. Let me go to our another panelist here before we go to the drugs, because I want to cover that. Craig, what do you say?
Well, like so many things in politics, it's more important that they create the illusion that they're doing something than actually accomplishing anything. And there's so many bad actors in this whole healthcare marketplace, which is 20% of the GDP of America, that you have to know, like Hobson said, these things are going to be litigated. So the legislation, while maybe well-intentioned, and it allows you to hang a flag and say, no, this isn't going to happen. We specifically said this. Between now and implementation of that, it will all have to be negotiated either in the courts or outside the courts.
Yeah, my take on it is it's far away from anything getting done that's worthwhile, in my opinion. What do you think?
It's going to cause more obfuscation and complexity and confusion than not having the numbers, because it's all the numbers. I mean, so it's still going to be which price. Okay, well, I work for an employer who's using Aetna, and Aetna's price at that hospital is this, but I can see that Blue Cross's price is that. I want that price. Well, you can't have that price because you're going through Aetna. I mean, I'm not. It's going to offer a lot of opportunities.
They're going to be able to bob and weave for a while and cover it up. Here's
what
I think, and we had a State of the Union meeting at my old office where I started after ACA passed, and we thought we were going to be out of business. Turns out it was the greatest thing ever to happen to us was the ACA, especially me being new. It just created uncertainty, high increases, which created what, Craig? Opportunity for a young guy in the business trying to make his way with self-funding. So how much is this going to help us in the self-funded world? Most of our listeners here are trying to do the right thing for their client, provide them self-funding. Might not always be the right thing, but everybody's trying to take them self-funding. Is this going to open up more opportunities, in your opinion, with the loaded costs and administration of these changes that you see on the horizon?
I think it has propensity to add, like I say, confusion. I think brokers are going to be asked questions about it, and they need to be able to come up with some kind of answer for what it means. But right now, you know, it's going to be a while. I don't think we're going to see much of anything happen to anything that's going to take place in 2021. The earliest that anything of all of the different players can have an impact, I think the earliest is 22, and probably not even then. We're probably going to have to get to the 22 election. Why? Because it's going to depend a lot on the Senate. I mean, and that's why it's one of the players too. If Biden wins, but they don't win the Senate, then all the things that he wants to do with that has an impact on healthcare and employer benefits, it's gonna, you know, have to go through some. Now he talks about working across.
What lay out to the audience? What does he actually want to do? What's in his plan that you see?
Well, it's mostly he wants to keep what are viewed as the good aspects of Obamacare, and then add Biden care, which is the public option. The public option was the thing that was touted to be in the original ACA, but if you go back and look, it was something that had to be sacrificed in order to get that slim margin in the Senate in order to get them to pass it. So it was sacrificed. It was one of the bellwether items that, of course, the progressives and the left really wanted, because they saw that as, and rightfully so, maybe as the first strike on the stake into the heart of private healthcare. And it would be, again, depending on how it's done. The public option is simply an individual plan that wouldn't be run by an insurance company, right? Like the exchanges are. The exchanges are insurance company plans. So there would be a Medicare-like option for the people who would otherwise be eligible for the exchange. And of course, the big question there becomes, well, are they going to have the same? Are they going to have Medicare rates? Or are providers going to be willing to take Medicare rates for people who are 55? And that'll just shift more cost to the rest of us, okay, for the people who take that option. And that's again, that's the stake, the first drive of the stake that was hoped for by the left. So it all depends on what they mean by the public option. What are the payment rates going to be? Because every time more and more people are, the providers are being paid at a Medicare level for more and more people, the providers are looking and saying, I'm not getting my revenue. I have to adjust it someplace.
I think I was talking to Craig before the show. Is Medicare, is Obamacare and the big whole scam here, the government allowing Obamacare and the raise of cost of premiums to offset their costs, and essentially subsidize or tax the employers because they don't want to kick up more costs for Medicare. They allow the Medicare payments, even though they claim losing money, which you verify to me that they are need about 120% to be profitable of Medicare. But they allow them to run wild on the employer market because, well, that'll keep us from having to pay more.
Well, yeah, I mean that gets into the whole theory behind what's reference-based pricing and what does the Maryland all-payer system secret the secret file they have about how it works, but they don't want us to know about it. I mean, you think Roswell is secret? The success of the Maryland situation, makes that look like nothing. But it's my belief that based on everything I've seen, and this is guessing about it, but even if you look at that new RAND study too, by the way, I think you would end up concluding that probably somewhere between 140 and 150% of Medicare for hospitals, not doctors necessarily, is about where that balancing point is, where if everybody was paying that, Medicare included, in other words, paying 50% more than they are, that would allow commercial carriers to pay a whole lot less than they are, and they'd all meet in the middle at about 150%. But that would imply that an admission that hospitals have been being underpaid by Medicare, not every hospital, but the bulk of them as a whole, have been paid too little. Now, there will be a lot of people that will argue with that and say, no,
they're not looking to make profit, right? They could lower their price.
I think what this points out is that it's so much more complicated than saying this is all we have to do. So if you extrapolate, the first order consequence is usually easy to see. The second order is the thing that nobody ever wants to think about, because we love sound bites, we love easy, we love quick, we love recency bias nowadays if you're under 30. And so what happens when you have that scenario where now commercials paying 140 or 50%? Well, suddenly the Medicare payroll tax is drastically inadequate because we have so few workers relative to the Medicare population, and now 96% of all payroll receiving adults in America will have to have their taxes increased in order to subsidize this. So now you have a whole second order of consequences that nobody's perceiving. And it's the reason why we basically are living what's referred to as the Shirky principle. Institutions will try very, very hard to preserve the problem that they are perceived to be the solution of. And so we end up going around and around, never solving the problem.
They go ahead, Hop.
Well, I mean, the fact is that 40 to 50% of the hospital resources are taken up by Medicare and Medicaid, and throw in the VA and throw in the federal employee benefit program, et cetera, et cetera. I mean, we're already mostly publicly paid, but as far as the rates that the hospitals are getting, if in fact they're getting paid too little, and all evidence seems to suggest that across the board, they're paid about 92% of what Medicare says is their cost. Okay, well, what does that mean? I mean, that means that they're being paid too little. Well, they should be more efficient. That's the answer that comes back.
They can't run a P&L on a single thing they do there. I mean, run a P&L on an appendectomy. They go, huh?
Well, most of them have no idea what that costs, right? I mean, they don't do cost accounting that way in most hospitals. Some do. Some systems do a very good job of it, and they're, I mean, they keep saying, well, we have to charge more in the emergency room because, we have to cover the loss. Well, why do you have a loss over there? Charge more over there. Well, we can't do that because, it's like the hospital down the street doesn't do that. And, well, then you find out there is some competition. Well, at any rate, this is why fixing this is not going to probably be piecemeal. But I mean, if they go back to the public option, they have to decide what is the public option going to pay. All other public options are like Medicare and Medicaid; they don't pay more than Medicare, right? So if that happens, it's another cost shift to the commercial market, just like the president's pharma deal. Okay, his deal to make the pharmaceutical prices. I know you didn't want to go there yet, John,
No,
but
no,
it's
I want to hear it.
part of this. It's part of it.
I was keeping my powder dry, but we'll go there.
It's only for Medicare. It's not even for Medicaid. Well, if pharma lowers their prices to meet that requirement that they're going to be equal to the favored nation price of the 8 first world country price, okay, for the United States for Medicare, and that turns out to be 30 or 40% less than their average take now, where do you think they're going to shift it? Because that rule doesn't apply to the rest of us. Okay, it should. The price should be set on a national basis, and so that we know what the price is, no matter who the payer is. You can have an all-payer system for drugs too. It works perfectly well, but no, that doesn't allow people to do deals.
Trump's going to make deals, he said.
Say what?
I said Trump's going to make deals.
What?
Right?
There's only so much you can do when the healthcare industry, the industrial complex, is the largest lobbyists in the country.
People ask me all the time, is Trump going to do this or his plan? And I say, look, he thought he was going to be able to come in and slap them around, and you didn't realize how big and powerful they were. He tried to, what did he do? He tried to put an executive order for the gag clause, I think, and it got thrown out. So, he's not even able to get little things through. Is he going to be able to get big things through that we keep talking about? It's not happening. Here's the news. Employers are going to keep paying more money. The publicly traded companies are going to continue to figure out ways to juice up their profits, pay their shareholders, make their corporate America rich. It's just a reality. So the good news is it creates more opportunity for you if you understand health plans. You understand what we're doing at Virtue Health. You'll have a competitive advantage. John Clay today took over a broker record. Group didn't know what the hell they were doing. Took them self-funded. Broker took them self-funded, not in the right manner. He implemented one solution for them while they had their broker, saved them double what he promised. Now he's the broker of record. So you've got to know how to cut the costs for employers. The fix is not coming in anytime soon. Hob, I want to go to you for a second on this point. Beth Johnson says 100% correct. Got to get to Medicare break even. So, Hobson is the actuary over at Virtue Health's Planet down at Intrust, and you guys are super advanced, right? You're in Texas. You and Robin Help wrote the bill of transparency down there to get claims data. You pretty much have direct contracts in almost every market in Texas. What is your program look like that's been effective for an employer that you see, hey, we could take this nationally if we were able to direct contract in certain markets? What does that look like versus the PPO?
Well, I mean, to combat the pressure on prices is just simply going to continue no matter what happens with all these political players and this stuff, at least for several years. As long as what I'll call the ERISA Maginot line, and hopefully they don't go around it, okay? But as long as that defense is there, the self-insured industry and the self-insured employer is going to be able to do things to combat the increasing prices. And of course, the way you have to do that is try to get control of knowing what the price is. And you can do that if you say, look, I'm going to pay according to this measuring stick, which is Medicare, and I'm going to allow so much. And then you say, well, we'd like to find some providers who will do that. And so you do that via the direct contracting platform, where you go and you talk to them and you say you're going to direct some business there, etc., and you're going to incentivize people to go there because you're going to waive the deductible. The hospitals love that when they don't have to chase the ever increasing deductible dollar from the patient. And that's what I do need to correct you on one thing. No, I wasn't working too much with them at the time that Robin and Ed were the ones who did all the work in Austin back in the first part of the decade to get the Texas the transparency experience transparency law passed. So, but yes, then I joined them and we started working on the transparency stuff, and we're still trying, and it's going to be interesting to see what happens. But you try to get control of the major part of your spend and know what the price is, and then get that direct contract. I mean, and more hospitals are being willing to negotiate direct contracts. Now, they might not be at 125% of Medicare. In fact, they're probably not going to be, but they're not like 250% of Medicare either. The RAND study, by the way, the most recent RAND study, or if you're familiar with that, which is the largest study that actually takes claim data from the group commercial market and reprices it at Medicare, and then does a comparison by state, by hospital system, et cetera. It's still a smidgen of data in the total, but it's much better than it was, and it's better than nothing, because we really have nothing else that does this. Shows, if you trend it out to 2021, shows that the average commercial facility charge for 2021 allowed amount, this is after their discount, right, is going to be somewhere between 295 and 300% of Medicare. Now, it's a bit less than that for it might be 270 for inpatient and like 350 or so for outpatient. I'm doing a little actuarial license there to get to that number, because their study kind of messed things up this year. But that data just came out in May, and you can get it and look at it by state. There's a very interesting.
Sounds like we need a observation. Can we get a observation on that one? A little article? Those that don't know.
Actually, I'm trying to work on one. I'm not sure. I've been trying to work on it for several. I've been trying to communicate with the author to ask them to please clarify a couple of the things that they said, and they're dodging me. So I'm trying some end around.
You've been doing all of coronavirus. I thought I'd see observations coming out left and right.
Well, right. But anyway, I wanted to give them a chance to confirm my impressions of some of the numbers that they just throw out in the article. But anyway, it's still very good as far as finally getting to answering this question. But there are issues with, I mean, and they admit that there's caveats in terms of the amount of the data and stuff, but not in the methodology. So, I mean, there it is in black and white. So if you're doing reference-based pricing, or you've got a direct contract that's 190% of Medicare for facility in a urban environment where the average, or in a state where the average is 250 to 300 for the PPOs, right? Well, there you go. You know, you're going to save 20 or 25% on the facility charges. Now, you still have to deal with things like the emergency, the trauma, and lots of people are working on ways to try to deal with that fear. The problem with RBP for an employer considering it, right? I mean, it's all fear. It's fear of the unknown, fear of what might happen, fear of that example that you give of, Mary, who was in Boston and was in a car accident and was burned badly, and it was a $800,000 bariatric claim. I mean, it's like, and they want to know what are you going to do about that? Well, you can write your plan document in a way that takes care of that, or you can enlist the aid of patient assistance and things like that. And some of the legal protections, they're starting to be, in addition to the ELAP and the AMPS, they build it into their system, and you pay for it with a huge percentage of savings. There's starting to be some balanced billing, legal protection programs out there that you buy as a PEPM, and they will probably deal with 99% of that stuff. It's an evolving, dynamic market, and as the demand goes up, there's going to be more people coming in to help you deal with that. But you narrow PPOs are still, you're sacrificing something if you go to a narrow PPO, right? Somehow or another, you're sacrificing something. There's always a trade-off, and taking control of it by getting a direct. Now, some markets are very difficult to get direct contracts in. Just about any rural market is going to be difficult.
New Jersey, California.
Yeah, and so some places in Ohio and some others, but interest is starting to get its wagon circled in Texas, in most of the metropolitan areas. There's still some we're working on. It's part of the 90-degree benefit team, and we're trying to find out how we can do cross roughing with with other TPAs direct contracts and try to get a broader. I don't want to use the word network.
Have TPAs considered combining and saying, look, we've got we're competitors, but we got X amount of lives in this market. Let's bind together and push to get a direct contract in this market with our membership. Has that happened or thought of happening, or everybody's just too damn competitive?
Well, there usually has to be some entity that sits on top of it and is sort of making that happen, and not so much yet. I do want to throw out an idea that came to me from a colleague, an actuarial colleague, who I've been having an ongoing discussion about this idea, and she was asking, do any networks offer a percentage of Medicare guarantee? I.e., we guarantee that your total spend over the year, when we throw it all together and blend it all together, won't exceed more than 200% of Medicare or 210% of Medicare. And my first reaction was, well, they're not gonna do that. But first of all, they'd have to recalculate everything at Medicare, and nobody wants to do that. But then I started thinking, maybe that's not such a bad idea. Or it probably is better to build one up from scratch, bootstrap it, and just use your direct contracts and try to piece together. I don't want to call it a network, but an association of participating providers or something like that, and say, look, we think overall, throwing everything together. Of course, you got to mix the lower ratio provider physicians with the higher ratio hospitals, but that's not always the case. In Minnesota and Wisconsin, the average commercial rate to Medicare,
also known as Wisconsin.
Oh, anyway, one of the things the RAND study shows is if you look at the professional ratio, it far exceeds the facility ratio in those two states. And then almost everywhere else in the country, the professional ratio is lower than the facility ratio. But in those two states, it's the other way. And I guess it fits with what I understand some of the power of the medical practices up in those two states. It's very interesting. The RAND study is worth glancing at, even if you don't want to mess with a lot of the numbers and stuff.
It's a great commentary. You just mentioned that we always have to point out to brokers that when you read stuff and you read posts and sales organizations tell you about doing this, that, and the other thing, what they rarely tell you, because most of the people pitching these things don't actually have experience doing it, they're just marketing packagers. Healthcare is local. Healthcare is regional at best. And so when you have larger employers with national locations and presences all over the country, it's very challenging to roll out national plans, especially when you want to use some of the state-of-the-art things, if you call RBP state-of-the-art. But the 4 versions that now exist after 10 years of doing it plus are ever evolving. And so it's just like you said, there are markets where you can play and markets where you can't, whether it's direct contracting or RBP or high performance networks. That's a common phraseology instead of narrow networks, Hobson. High performance networks.
Oh yeah, well,
yeah.
That's the euphemism, right?
It sounds better.
One other thing I wanted to make sure to mention to people tonight is to not forget as we go forward is the ultimate meaning of or possible use in terms of strategizing of the premium HRA. Okay, I'm kind of amazed I haven't heard a whole lot more about it. A lot of talk about it. But even first it started with just the small employers, but now any size employer can, with the rules about the classes and things, you can set up an HRA plan that, for a class of employees that you have no health plan for, but you say, I'm going to put, X dollars into this thing and you can use it as to go get an exchange policy. I'm not sure, Craig, maybe, if you can use it to pay the premium for to join your spouse's policy or not. I'm not sure about that, but it's, And there are, that's something that people were asking for 10 years ago. Was like, well, why can't we just put money in and let them go buy their own plan? Well, now you can within rules, okay, and the rules are somewhat stringent. You can't just put sick people in there and say go to the exchange. You got to be legitimate organizational classes, etc. But that is a tool that brokers, especially in the self-insured marketplace, should start thinking about. When is it better to be? And I'm not talking about just putting a couple of $100 in there. I'm saying, look, if your plan is costing you $3,000 or $4,000 an employee a year in employer contributions, we'll put that in there. At least it gives you a defined benefit, right? A defined contribution that is the benefit that you have to pay. You don't have any guesswork as to, well, what if somebody has a premature baby? So I'm not saying run out and just do it on everything willy-nilly. I'm just saying keep it in mind, okay, that it's there now, right? We should be learning more about that and when it might be useful.
Correct.
And that is especially subject to local market conditions, because some states don't have individual policies. Others do. So again, buyer beware. ICRA is not for everybody.
Well,
I think there's going to be a lot of future planning, as you just alluded to, for companies who want to get creative, that have a consultant that can go outside the box and give them advice that's a little bit different.
Well, every state's got at least exchange individual policies.
They can be pretty stinky, though.
Well,
some of the markets are really bad.
Yeah. Granted, I didn't say I wasn't
compared to the group coverage. You're not going to want an individual policy, so you just have to be careful.
And that may be. But the thing is, if there was more of this, the market might, if some of the perhaps the new administration would be willing to modify some of the rules on it. And I'm not saying go to short-term type policy rules and pre-existing conditions and can be restricted and all that. I'm just saying, look and say, I'm in favor of basically doing away with Medicaid and just giving them the money to buy into the exchange. Can you imagine how that would change the population-based pricing calculations the actuaries would do for their exchange policies? To see an influx of all those.
The insurance companies would lose money, so that's not happening. They can't overbill insurance.
They wouldn't necessarily lose money at that. Those people are probably healthier than a lot of the people in the exchange.
They're not going to be able to rip them off as bad as they are.
Well,
so, look, those Medicaid.
They might need to relax some of those rules, is all I'm saying. If they did, the individual market could take off.
John Clay says, exchange is a death spiral. Yeah, everybody, I think, kind of known that when you run into an employer, and had a call today, somebody talking about a franchise and setting up a association, and I said, they can't get good rates because they're so small. I go, so what do you think? Because they're gonna have more employees, they just get better rates? That's not how it works. So I always say that question, or I talk about that in seminars when they say, I'm too small, and if we get some people together, group buying. That's why I say use group buying to fill up seminar seats. They believe it. They think it lowers healthcare costs. I said, so if you want to look at a big pool, just look at the individual market. How's that going? Right, not very well. So the more members you have doesn't mean shit if you're not managing the cost. So that exchange is probably is that heavily subsidized even on top of what they're charging, Hobson?
The individual exchanges?
Yeah.
Oh yeah. In reality, I forget what the calculation actually is, but I think it's around 2/3 of the money that is used to purchase exchange policies is our money, is taxpayer money. Okay, it's something like 75% of the people get some kind of subsidy, and most of them get like at least 80%. So it's like you end up with a product of about 2/3, somewhere between 60 and 2/3. So they're already, they're definitely
they're subsidizing, but even on top of the subsidy that they give to the employees, is there some sort of subsidy or tax that we don't see? That, let's say they charge $500 premium on the exchange, subsidy gets them down to $300. Before that, we get to that $500, is there a subsidy behind that, a tax that they're using to drive that down? Because you almost look at it like it's almost like a high risk pool to an extent, because it's garbage.
It has stabilized. The actuarial view, if you will, of looking at the exchanges from the time they started, and yes, some of the predictable stuff was some of the predictable stuff happened, and it was a nightmare, and etc. But it's kind of stabilized over the last 2 or 3 years. You know, the rates have stabilized. The companies are not losing. Yes, in some states, in some markets, yes, they are, but not in general. They've kind of got an equilibrium. They've finally reached the point where okay, now we kind of understand the population we have, and especially given the fact that the mandate's gone. Okay, I mean the population has stabilized. Now, COVID has thrown them a wrench because they've had a lot of people have to drop out and go to Medicaid. Not as many people have been coming in because they lost employer coverage. There's been this migration from employer market to individual market or Medicaid, excuse me. Most of it's been Medicaid has seen the biggest gains by far. Now, these people are not necessarily sick. Okay, their health on a population basis might not, they've lost coverage. They've lost their income. Okay, and the government didn't act fast enough to offer to pay for all the COBRA. If they had passed the bill that said that they were gonna basically pay COBRA, okay, that would have been a godsend for lots of us, because I mean it's like everybody would have been doing, not just sick people. Usually you think COBRA, okay, coverage of last resort, that's a high risk pool, but this wouldn't have been. But they didn't do that, so people have just been leaving, and those who can qualify might go get a subsidy. But if they lost too much income, then boom, they're down to either Medicare, or they're in a state like Texas where people between 100 and 132 don't get any coverage, and there's a lot of people there. You don't qualify for Medicaid, and you don't qualify for a subsidy.
What income?
Huh?
At what income?
I'm trying to remember. I think it's between 100 and 132% of the poverty level, something like that.
Frank, stable does not mean affordable, Hobson. Oh, that's true.
Well, again, with the subsidy, yeah, but Medicaid is ultimately affordable to the patient, to the beneficiary, because there's no cost sharing. I mean, and no premiums to speak of. It's like, but the people who fall into the gap, okay, the people who in the states that did not expand Medicaid, which was the expectation at the time the ACA was passed, is that we wouldn't have these gaps. Well, we still have these gaps, and COVID is basically, picking at that like a scab and making it worse, because it's of this population migration because of the economy.
Correct. What do you say?
It's complicated, isn't it? Yeah,
it definitely is.
There's a lot of reasons. There's almost 4 trillion reasons why this stuff doesn't get fixed.
Hey, look, the good news
they all have
is
dollar signs in front of them.
Yes, sir.
With all these crooked people in the industry, gives us honest guys that I question sometimes. Why are we being honest? But hey, it's integrity. Us honest guys creates opportunities for us in the market. So that's what you got to look at it as. All of this means opportunity. Am I happy employers are paying more? No. But it gives us the opportunity to help employers, help prospects, clients, so on and so forth, and be the hero. So, look, there's nothing funner than delivering results to a client year over year and showing them. I mean, I can't tell you how many renewals I did for 12-1 and 1-1 that I was like, hey, check where you out. Some of them I had to dig so far into a file. It was like 7 years ago. And I'm like, we are paying less now than we did 7 years ago. I mean, it's unbelievable if you get things under control. Not every case 7 years, but a lot of 5-year cases where it was like 5 years ago, hey, we're still paying less. So got to do the right thing.
You got to have a lot of prospects, because what do we know about human nature? A lot of people will procrastinate. A lot of people don't want to know the truth. They're comfortable drinking the poison that they drink every day. They're comfortable not hearing anything that doesn't validate what they already believe. They don't. Change is a 4-letter word that sounds like work. Take your pick. So not everybody's ready to actually do what it takes to control their healthcare claims. Although we all know on this call, and many of you watching know that it can be done. And so you've got to have a lot of prospects, because this kind of uncertainty and volatility is fantastic for business. But you've got to go out there and hunt.
Talk to a lot of people. I'll leave you guys with this before I give final thoughts to Hobson. So I get a call with an owner and referred in, and I take her down. What do I call it? The counter selling method, basically using everything against them that they say. And I take her down these questions, and she starts telling me, she just goes off. I just ask the right questions. I hit the pain, and we're losing employees over it, shifting costs, so on and so forth, all these problems. And, great, I'm going to send you a consulting agreement, go over it. And my fault, made a mistake here, which I admit we always make mistakes. And I sent the consulting agreement before the call, just too soon. And she fired an email off, and she said, "Thanks for the contract. I've just received a revised price reduction from Cigna this morning as requested. They reduced their increase to 3%, which I will accept because I need to close this out by Monday. Given that very short window, I think it's best we move forward and look at the benefits review for next year. That way I'm in a better negotiating position." So guys, you can lead them to the water. You can let them cry the blues and this and that, and they're trained. What do you call it, Craig? The elephant trainer?
Elephant trainers.
She thought that's going to put her in a better negotiating position. Now, she doesn't understand the fact that, buying the insurance isn't solving the problem. It's managing the risk and putting her in an arrangement that can manage the risk. And I told her not a lot, but enough on the first call. And I came in with a lot of credibility, from the CFO group, and it was an owner. And look, I told my partner that got me in, I said, "Look, man, here's the reason why you need to get me 10 prospects, because most of them are going to give you the same bullshit answer." So just leaving you with that note for those of you that are banging your head in the fourth quarter with new prospects. Hey, look, I'm dealing with it too. So keep at it. Final thoughts, Hobson. What do you got?
Well, I think keep an eye on, what is it, about 2 weeks from today, not for the election result, but for the HEA case in the Supreme Court. There could be a lot of, monkey wrenches thrown into the system. I mean, I don't actually believe that and they probably won't decide it in one day. Maybe they will. I don't think they're going to nix the whole thing. I think they're going to bring severability into it, even though I think Congress intended for it to be non-severable, but whatever. That's going to be important. But I think that the word would be, look, unless there is a blue wave of unbelievable proportions, so that there's absolutely no questions in Congress about doing whatever they want to do, sort of like what Obama had in his first 2 years, even easier than Obama had in his first 2 years. Not a lot is going to change on the ground for the self-insured world for at least a couple of years, and we'll be able to see what's coming, hopefully. And in the meantime, the cost pressures are going to be there, and these guys offer you the tools for mitigating those cost pressures, offsetting those cost pressures, and even gaining against them, as John just talked about. Having cases that have been flat or even come down over a 5-year period. It's possible it depends a little bit on where you start out, but there's an amazing amount of stuff that's going to be able to still be done. Don't get distracted by all of the whistles and buzzes that are going on out of DC.
Yeah, I think, guys, look, there's a lot of solutions out there. You got to have the balls to tell your client what to do. They hire you to be told what to do. A lot of you, unfortunately, think it's your job to get rates and peddle it to them and say, "Here, I did my job." That's an insurance peddler. When you get the rates and you hand them, you're peddling numbers. Tell them what to do, whether it be fully insured, self-funded, I don't care. They hire you to tell them what to do. Craig, final thoughts?
In business, don't play checkers. Learn how to play chess. You got to think multiple moves ahead.
There it is, guys. Thanks for joining us. We will see you on the next one. Good luck in the rest of the fourth quarter. Next week, same place, same time, 8 p.m. Pacific, 5 p.m. No, 8 p.m. Eastern, 5 p.m. Pacific. We'll see you guys. Take care. Be good.